So I'll go ahead and just introduce everybody to Dr. Sarah Redding from the Pathways Community Hub Institute. She's the founder of the Pathways Community Hub Institute, and for more than 30 years, she's worked with community health workers across the country, developing educational programs and providing training. The PCHI model is designated to transform communities through improving outcomes and for those most at risk. Dr. Redding completed her specialty training in general preventative medicine at Johns Hopkins University, and she's going to talk to us about an in-depth little overview of the model. So we appreciate it, Dr. Redding.
Thanks, Brian. Lily, we could go to the next slide. And I want to go back a few steps and talk a little bit about how we even came up with this model in the first place. That's, we weren't just sitting around one day thinking, let's do a model. My husband and I spent time in Kotzebue, Alaska, above the Arctic Circle, and that was our first encounter with a community health worker. Had never heard the term before, had no idea what they could do or how to use them, because we weren't trained on that when we went through our medical training. But by the time we left Alaska and moved to Baltimore, really didn't know how we were going to do our work without a community health worker. It just seemed like this insurmountable task. I was fortunate in that I was able to work with the Baltimore City Healthy Start program at the time, and they were using community navigators, very similar to CHWs of today. And we did a lot of great things. We, had a great group of women. We had college level training for them. We were in the right communities to be served. But I watched what happened when the grant funding went away. And who do you think were the first people to be let go? The CHWs. So we had spent all this time and all this effort, and we were really seeing good impact, and they were the first to let go. And back then, there really wasn't a lot of other opportunities to move into if you were a CHW. It was pretty specialized at that time. So when we moved back to Ohio, where we're originally from, our first inclination was to not do anything with CHWs because it was really frustrating, but realized from the experience in Alaska that CHWs were just too important to let that concept go. So we started the Community Health Access Project based in our own county in Ohio, really with just the mission of, could we get CHWs to work with high-risk pregnant women? So the next slide is actually a picture of our very first group of community health workers, great group of women. They were already involved in their churches and community-based organizations. We had great training through our local community college that we developed. We did hot spotting before anyone thought to call it hot spotting, but we knew where the poor birth outcomes were happening. And they did their work. They went out to serve the high-risk pregnant women in our community. But when we looked at our data about a year and a half in, we weren't making a significant impact. We had a lot of good stories, but it was really hard to evaluate the data that we were collecting. And looking back now, it was unfair to put community health workers into such a fragmented system and think that they were going to be able to fix that. So that was our first big lesson learned, is that it took more than just putting CHWs out there. Our first development was actually creating pathways. In our model, pathways are a tool that the CHW uses to measure every time they identify a risk factor that's modifiable from identification, track through to mitigation or elimination. So pathways were our first kind of development in this model. The next slide, our CHWs taught us really early on that we could not do this fragmented approach anymore. We were physicians coming with a very medical focus, and we were taught by our CHWs that you got to get people housing, you got to get them food, and you got to get them jobs, or their healthcare is not going to get better. So the next slide is where we are today, where we approach everything with whole person care, that no risk factor is more important than any other risk factor if it's getting in the way of a good health outcome. I'll show you a little bit farther on some of the data from that original study of using pathways, but we were seeing a big impact suddenly. And that was great, but we were one organization in a very large county, and we weren't going to get to health equity through one organization. And I'll make that argument no matter how large of an organization you're representing. it's going to take the community. It's never going to be one hospital system or payer or state agency. It's really got to be the whole community. And out of that evolved the Pathways Community Hub approach. The next slide gives you a working definition of a Pathways Community Hub, and we'll break this down. But the Pathways Community Hub is an organized, outcome-focused, pay-for-performance network of community-based organizations and others that hires and trains community health workers to reach out to those at greatest risk, identify risk factors and barriers, and assure connections to medical, social, and behavioral health services. And we'll talk through each of those parts. The fascinating thing is that Pathways Community Hubs start out by addressing individual risk factors, but by addressing those, we start to see community level change. And we employ a quality improvement framework in that work. Pathways Community Hubs also have outcome-based payment. It's the only model we're aware of with community-based care coordination that has that in place. But it's a way to build sustainable funding for the workforce doing this work. And what we've been able to show is that a certified Pathways Community Hub not only improves health, it reduces costs and promotes health equity. So the next slide is just giving you a picture of who can we serve with the Pathways Community Hub. And so far, we have not found any population we couldn't serve with this model. Clearly, all of our Pathways Community Hubs are working with COVID-19 right now. Some are focused more on maternal and child health, some more on chronic disease, some on criminal justice. Many of the mature Pathways Community Hubs deal with multiple populations at the same time. The next slide is a visual of a Pathways Community Hub. So PCH is our abbreviation, and the Pathways Community Hub is in the center there. It's the dark blue circle. A Pathways Community Hub is small. Usually when they first start out, they're only 3 people on average. But what a Pathways Community Hub is doing is going out and recognizing all of those community-based organizations, federally qualified health centers, other agencies and organizations that could employ community health workers, either are employing them or are willing to employ them, and contracts with them to form a community-based care coordination network. So the hub comes in and puts the infrastructure in place. All of those organizations were existing before. The hub just brings them together into the network. The most important part, though, of the network is the circle to the left with the community health worker and the family being served. Whatever we do within this model, we recognize that is the most important relationship, and we don't do anything to disrupt that. The Pathways Community Hub not only contracts with agencies in the community, but goes out and contracts with funders that will support this network. That might be health plans, it might be grants, it might be contracts at the local, state, or federal government level, United Way. There's a variety of ways that Pathways Community Hubs bring in funding. And in addition, the Pathways Community Hub will work to find referral partners in the community that will help identify people that could benefit from the hub, and direct service providers that are going to actually be providing the services. So the next slide, I want to give you a little bit more detail about the Pathways Community Hub. This is now a nationally certified model. It is under, the certification is at the Pathways Community Hub Institute. And there are prerequisites and standards that need to be met for a Pathways Community Hub. One of the most important, it has to be neutral, transparent, and accountable. So a Pathways Community Hub can't favor one hospital over another, one health plan over another. It is Switzerland in the community. It's not playing favorites with anybody. It's very important that the hub is perceived that way. There's only one in the community or region being served, and it has to be located in that region. It's key job developing that community-based care coordination network. The hub does not employ community health workers. It reaches out to others, again, those CBOs, FQHCs that are in the community that already have community health workers and contracts with them. We use outcome-based contracting, and we'll talk a little bit more about this, but it's based around closing those pathways or eliminating risk, the hub must have a community advisory council, and that advisory council needs representation from all elements of the community, from people being served up to decision makers. The PCH agrees to use PCHI's model, and that means our data definitions, our data collection tools, and pathways. The next slide just gives you a little information on who can be a Pathways Community Hub and who can't be. Sometimes it's easier to start with who can't be. And you'll see at the bottom, if you're a hospital, a clinical integration network, a payer, a healthcare system, a statewide organization, you're not positioned to be a Pathways Community Hub because you don't have that neutrality. So what we find is mostly it's community-based organizations that evolve into Pathways Community Hubs. Sometimes we'll see health collaboratives or hospital associations. And more recently, we're seeing accountable communities of health evolving into Pathways Community Hubs. The next slide, switching from the hub a little bit, we're going to talk about the Care Coordination Agency. Remember, the hub doesn't employ the CHW. It contracts with existing organizations within the community that they're the ones that employ the CHW and the CHW supervisor. But with the contract between the Pathways Community Hub and the Care Coordination Agency, there's an agreement to find any community member at risk, to use those 21 standard pathways, to agree to provide whole person care. Even if you're coming out of an agency that does housing, you have to know how to do all 21 pathways and be able to help people connect, and agree to the outcome-based payment methodology. It's important that these contracted agencies also agree to participate in governance and problem solving, because they're key, they're on the ground and provide a lot of information back to the Pathways Community Hub and the Advisory Council. The next slide gives you a little bit of overview of kind of the workflow that a community health worker within an agency would be walking through. We break it down to find, treat, measure. So community health workers find and engage individuals that are at risk in the community based on whatever the Pathways Community Hub decides is their target population. They build those trusting relationships. They do all of the connections to the services needed, and they use pathways to track and track all of those completed elimination of risks. And they do a lot of teaching, and I'll show you some of our strategies that we use within the model, but so much of behavior change revolves around teaching. So they're very engaged in that as well. The next slide shows you the 21 standard pathways. And I could spend probably the next 3 hours talking about pathways, so I'll try to be quick on this, but these standard pathways are used across every Pathways Community Hub. No matter what state they're in, they're using the same pathways to track these risks, measuring elimination of risk. 3 of our pathways actually expand and have multiple codes under them, such as the medical referral pathway, the social service referral, and learning. Why we have set the pathways up this way: for the community health worker, the process is very similar, whether it's getting somebody to their dental appointment or their vision appointment. There's key steps they need to walk through. So the pathway itself is the same, we just have different codes for the type of services. The next slide will give you an example of some of the outcomes. So remember that each pathway ends in an outcome that's measurable and meaningful to the person being served. So for example, the employment pathway doesn't end just when the participant gets a job, it's that they're still working 30 days from the date of hire at that same job. We'll see that kind of play out with housing pathways, where it's not just moving somebody into safe, stable housing, they're there 30 days later. So this just gives you kind of a flavor of what those pathways look like. The next slide is our medical home pathway. And this is one of kind of the simpler pathways. That's why I picked this one, because it's used when somebody needs to have a place to go for ongoing care. So every pathway, when we talk about the structure of a pathway, there's an initiation step. And this is, what is the issue that we're addressing? And in this case, somebody needs a place for ongoing healthcare. The start date is when the community health worker first becomes aware that this is an issue. A person may have needed a medical home for the past 5 years, but today the community health worker, in meeting and talking with them, realized that this is a risk. So that starts the pathway, and the pathway stays open until that risk is eliminated, until that person has picked a provider, scheduled an appointment, done everything they need to do to get into that provider and completed that appointment. And now they're enrolled into that medical home. You'll see that every pathway ends with not only the CHW signature, but their supervisor's signature as well. This is a billable unit within our model, so it needs to have kind of that extra set of eyes on it. But this is what a standard pathway looks like. The next slide. This is a new development within the model, and we're really excited about it. But as I mentioned earlier, a lot of what community health workers do is provide learning. And we have developed, I think it's 48, soon to be a few more learning modules that community health workers use when they're working with their participants. And that's related to use with the learning pathway. And these learning modules are designed to provide evidence-based education, but also to use open-ended questions, motivational interviewing, and the ask, tell, ask methodology. The next slide walks through kind of how addressing individual risk factors leads to community level change. So when we start over on the left, we're addressing things like, do people have food and clothing? Do they have safe, stable housing? Do they have a job? Do they need help with depression treatment? By addressing those risk factors through the pathways and completing pathways, we can prove that we've connected people to the services that are really meaningful to them. They now have safe, stable housing. They're now food secure. They've had a normal birth weight infant. But as we watch Pathways community hubs over time, if they're truly reaching out to the most at-risk people in the community and closing these pathways, we start to see large-scale outcomes. We start to see reduced hospitalizations, reduced readmissions. We see improved medication compliance, cost savings, which is always big. So there's this continuum. Even though we're working at the individual level, we see community level change. The next slide. I want to stress again, this model started with community health workers, and community health workers remain the foundation of this model. We see them as partners, coaches, and advocates for their clients. And these community health workers can work in multiple places within the community. We have community health workers stationed in schools and churches, again, community-based organizations, federally qualified health centers. That doesn't matter so much. It's the work of the community health worker and the relationship and trust building that they can provide that's missing so much in many of our systems right now. The next slide. I want to go back a little bit and talk about funding around this model. So the Pathways Community Hub, again, contracts with each care coordination agency that employs those CHWs, but also goes out and finds contracts with funders and payers and grants and private philanthropy that want to support, that want to pay for pathways, that want to get to these outcomes. And a Pathways Community Hub that is strong and sustainable will build many, many, many types of funding to come in to support that infrastructure, which also supports and builds the workforce. Because as a Pathways Community Hub grows, we need more and more community health workers to do this work. The next slide gets into a little bit about how we do contracting. And again, I could spend a while talking about this, but just to give you an overview, every pathway has a unique code and modifier assigned to it. But not only that, the Pathways Community Hub Institute has developed what we call outcome-based units, which is basically a measure of how much work goes into completing a pathway, knowing that sometimes you start a pathway and they're not going to be completed. We don't have the resources, we lose the person, whatever the reason is. So you can see if we look at something like the housing pathway, we assign 15 outcome-based units to that, where we assign 5 outcome-based units to a developmental referral pathway. What that means is if you're a brand new Pathways Community Hub, you can take the contract template and just negotiate the value of 1 outcome-based unit. So let's say we pick $50 for 1 outcome-based unit, and then we complete an adult education pathway. 50 times 10, that's worth $500. So the contracting has been done in multiple states now. We can certainly help in Nevada develop some contracts as well. The key thing here is that 50% of the contracts have to be linked to completion of pathways. That's what's important to the person being served, that we're eliminating their risk factors. The next slide. I want to mention briefly about technology. Now, PCHI does not have a technology platform, and that was a decision we made over 5 years ago to just keep our focus on fidelity to the model. But we have developed certification for technology vendors. So the Pathways Community Hub Institute, this is one of our newer certifications, is working with technology vendors that want to support Pathways Community Hubs. It's a pretty intensive process for them to go through. We really need to see that they're able to support and track all of the data that needs to be tracked for a successful Pathways Community Hub. We have 2 technology platforms that are actively being certified right now. Care Coordination Systems has reached provisional certification, and Innovacer is close behind. We expect them to be certified within the 1st or 2nd quarter of this year. The next slide talks a little bit about, does the model work? So when I talked about the original study with just our community health workers and our own agency reaching high-risk pregnant women, we published that data in the Maternal and Child Health Journal, and that's over on the right. And what we were able to do, we gave 3 years of our data to the Department of Health. They matched it to birth certificates. Then they gave that data to the Ohio State University Department of Biostatistics, and they did a case control match by census tract. So as much as possible, we were looking at women living in the same neighborhood as the women that we were serving with Pathways. What we found over that time period is a 60% reduction in low birth weight, which clearly translated into short and long-term return on investment. But what I found really fascinating with the data was that there was no difference in connection or use of OB care, but we saw that the women we were working with on average had 5 or more non-medical pathways. And those pathways were housing, childcare, transportation, employment, adult education. They weren't health-related issues per se. A more recent study on the left shows Centene in Ohio is called Buckeye Health Plan, and they looked at one of our largest hubs in Northwest Ohio. And they looked at women, their members who were pregnant that were connected to that hub. And they found that if they had a high-risk pregnant mom and she was engaged with the Pathways Community Hub, her baby was less likely to require NICU or special nursery care. And then they looked at the babies born to those moms, to all the moms. And overall, for the first year of life, looking at inpatient, outpatient, and pharmacy costs, they had a 236% return on investment. But if they specifically looked at the babies born to the high-risk moms, it was over a 400% return on investment. So clearly that's a win for the health plan as well. Better outcomes, cost savings. The next slide, and I'll just touch on this, it's just we have researchers working with Pathways Community Hubs across the country. We have developed a risk reduction research network that's really looking at those individually modifiable risk factors and how they combine and affect each other. But if we go to the next slide, I'm not going to go into this. I just want to point out This is a picture of our website, pchi-hub.com. If you're interested in any of the articles, just hit the resource tab up at the top right. And if you're interested in seeing where hubs are, these are specifically certified Pathways community hubs. You can hit the Where Hubs Are Working tab and you can visualize that. The next slide shows where we're working right now. We're in 17 different states. Some of these states have certified Pathways community hubs. Some are close to having PCHs that are certified, and some are just beginning and just starting that journey. We clearly were hit by COVID-19 too, and that delayed some of our certifications over the past 2 years. The next slide, I just want to end with, why would a community want to do this model? You know, what's the value to the community? Well, this is truly a collective impact framework, and it's a community-driven approach to improve health outcomes. Because once you put the infrastructure in place, you can address a whole variety of issues with the Pathways Community Hub care coordination approach. The other thing is that the Pathways Community Hub manages all of the partnerships and contracts and quality improvement and reporting, allowing the organizations that employ community health workers to focus on what they do best, which is serving the needs of their residents and not worrying about contracts and reporting and all of that stuff. That's done by the hub. Also, this is an outcome-driven methodology. If we're tying 50% of the contract to actually achieving outcomes that matter to the community, that's a win. The next slide talks a little bit about how Pathways community hubs can leverage resources. Clearly, what we've seen is that Pathways community hubs, once they get established, they're very good at going out and finding resources for all kinds of things around housing, transportation, employment, other social determinants of health. They're very good at finding many different funding streams to support the network that they've built. And again, to really emphasize, this is a great strategy to develop the community health worker workforce. So the next slide talks a little bit about, why would a payer be interested in contracting with the Pathways Community Hub? Well, number one, it streamlines their work. Think about going into a community and doing one contract, but having access to many different community-based care coordination agencies employing community health workers. That's huge. And they know that if they contract with the certified Pathways Community Hub, that they have gone through all of the prerequisites and standards and are true to the model, and they know what kind of data they're going to get back. They also have limited risk. Again, 50% of the contract, they don't pay unless there's an actual outcome achieved. But also we find that payers really value being a part of this process, being a part of building a hub and getting to meet other decision makers and community members as they go to meetings and sit on the Community Advisory Council. Their members also benefit by all of the other resources that the Pathways Community Hub secures and brings into the community. More housing resources, more transportation resources, more employment resources. And truly, this is a population-based approach. If they have a member that they're serving that for some reason falls off of their plan, they're still going to receive care coordination. So if they show up a year later, they're going to have had services in between the time that they left and the time that they came back. But probably the most important is the next slide. Why would residents want to have a Pathways Community Hub? So here's just pictures of two of our community health workers with people that they've worked with. And on the left is Maisha, and she said, "I'd still be homeless. I don't have a doubt. It was just a blessing. She didn't just help me and then leave me alone." Maisha was found by a community health worker living in a car with 4 kids. When her community health worker signed off, Maisha had housing, she had a job, all her kids were in school, they were all connected to healthcare. Things were going much better than when she was found. And for Judith's client over on the right, her statement, "I didn't know these services existed. The help really goes deep. It's wonderful." And I think that sums it up really well. The help really goes deep. It's not just hey, here's a phone number to call, or here, I'll check back, in 2 months. It's like, I'm your community health worker and I have enough resources and funding to make sure you connect to everything you need to get to be in a better place. So just to end, we'll go to the next slide. That's the end of my presentation, but I've got 3 questions for you as you go into your breakout groups. What interests you about the Pathways Community Hub Institute model? What did you find interesting about this? Number 2, how would the PCHI model align with work happening now in your community? And number 3, as always, what concerns do you have about the model? What are questions that have come up that you want answers to? So Brian, I'll turn it back to you.
Perfect. And we did have one question in the chat from Melissa. She asked if there are any existing partnerships with aging and disability resource centers, and if so, what does that look like? So before we get into the breakout sessions, Dr. Redding, if you could maybe address that real quick.
I don't know about resource centers, but we have several hubs working with like local area agency on aging that have community health workers that work out of their offices. So I'm not sure if that's close enough to what you're looking for, but we can talk offline too.
Perfect. Thank you. So for this next breakout session, it's going to be very similar to the first one. We'll break up into 5 groups with a Comagine employee in each one to kind of do the debrief. But we'd love to hear from you on these 3 questions. So any input or clarifications that you need, please ask, and we will do our best to answer the questions. And if not, we can refer them back to Dr. Redding once we come back to the larger group. So Manny and Lily, if you want to break us up, that would be great.